today. So I'm delighted to introduce Julian Gaskin, who is an ENT consultant, who's going to be speaking to us on ENT for primary care. If you're able to, I know lots of you will be in practice, but if you're able to put your cameras on, please do, because it makes it feel a lot more interactive and it's much nicer for Julian if you can see some faces looking back at him. There will be a bit of space at the end for cases and questions. So if you've got any cases that you want to bring, questions you want to jot down, please do, because there will be time for that. But equally, Julian, I'll monitor the chat if you can't see it whilst you're presenting. So if questions pop up, are you happy for me to let you know as we go through?
Yeah, that's fine.
Brilliant. So without further ado, I'll hand over to Julian. Thanks very much.
Well, thanks both for inviting me. So my name is Julian Gaskin. I work at the Bristol Children's Hospital. I primarily look after children, ENT issues with children, but emergency adult cover as well. So I was asked to give a talk, and these were sort of the suggested topics that people wanted me to talk about. So I've got obstructive sleep apnea, or OSA, recurrent tonsillitis, otitis media, of which there's 3 types: acute otitis media, chronic suppurative otitis media, and otitis media with effusion, which is glue ear. Tongue tie was on the list. Laryngomalacia was on the list, and I thought once we've got through those, if there's any sort of other things that people want to talk about, I've got a couple of other suggestions as well. We can talk about those. So if we start with OSA, OSA is the most common cause of OSA in children. It relates to adenotonsillar hypertrophy. So if we remove the tonsils and the adenoids, normally OSA resolves, but that's in children. In adults, it's a bit different, and the most common cause in adults tends to be due to being overweight or obese. But obesity is becoming more of a problem in childhood. We are seeing more of that in children. And then the other group can be patients with sort of neurological problems or syndromes, and that often causes hypertonia. They often have larger tongues that can collapse backwards, and craniofacial abnormalities as well can cause obstructive sleep apnea symptoms. But in general, the most common issue relates to big tonsils, big adenoids, and if you remove those, that normally solves the problem. Just having a slight issue moving the slide forward. Okay, so look, you know all of this, but it's just to put it up as a starting point. So when we talk about the tonsils, we're actually talking about the palatine tonsils, and you can see on the picture that that's, you know, either side of the mouth, and you look in and you'll see, you know, either, you know, varying degree of sizes of the palatine tonsil. The pharyngeal tonsil is what we call the adenoids, and they're at the back of the nose, and you can't normally see the adenoids. So the only realistic way of seeing the adenoids is if I put a flexible telescope via the nose and go to the back of the nose. And a lot of children won't tolerate that, particularly between the ages of 1 and 5. They will just not be able to tolerate that. But often we don't need to look at the adenoids, because if they've got big tonsils, normally the adenoids will go hand in hand. And then we've got the lingual tonsil as well, which is at the base of the tongue, and that's not normally something that we have to deal with. So I always talk about a sort of a spectrum of disease with OSA, with mild snoring at one end and severe obstructive sleep apnea at the other. And snoring we don't need to worry about. And you know, children are safe with snoring. They'll snore, it'll disturb the whole house, but actually that child's not coming to any harm and not having any issues. Severe OSA we need to treat surgically, and I'd probably put moderate OSA into that as well. And I would be normally thinking about, if they've got big tonsils, big adenoids, removing those in the first instance, regardless if they've got other things like, you know, if they're Down syndrome or other things like that. And the grey area is mild OSA, and that might be where they're getting some obstructive sleep apnea symptoms, but it's not every night. And that is a grey area, and I have to sort of then try and work out the best way to manage those patients. Sometimes that might be with a sleep study, and I'll talk about that in a second. So, as we mentioned, snoring is safe. About 12% of children between the ages of 4 and 5 will snore on a nightly basis, and you don't need to worry about snoring. So I don't want to operate on that sort of patient. That patient won't benefit from having their tonsils or adenoids removed. The risk doesn't outweigh the benefits. With OSA, there's a small proportion that can have complications, and so the sort of symptoms that might be concerning as poor behaviour and particularly poor performance at school. And they can also have nocturnal enuresis as well. So those patients that have OSA symptoms and they've got poor behaviour or they're bedwetting, these are the patients that probably need to be having a low threshold for referring them for having their tonsils and adenoids removed. In severe OSA, it can often have impacts on the heart and the lungs, and pulmonary hypertension is a potential risk, but that's in a very sort of rare, exclusive group of patients where it's very severe. So this is the sort of image that you'll probably see in your practice. You'd be looking in the mouth, and these are what you'd term as kissing tonsils, aren't they? And I'd call them grade 4 tonsils. So we grade it 1 to 4. So 4 is where they're touching. So these are huge palatine tonsils. This is the view that you're not going to see, and probably the view that I won't see unless I'm putting the child to sleep, or if they're older and I need to have a look in their nasopharynx. So these are the adenoids, and this is looking in the left nostril all the way to the back of the nose. And the adenoid is this tissue, and over here on the right, that's actually the eustachian tube opening. And sometimes the adenoids can be so large that it blocks that, and it causes glue-ear, otitis media with effusion. And so sometimes if we're treating otitis media with effusion, we might put a grommet in, and we might think about removing the adenoids at the same time. As I said, if I remove the adenoids and the tonsils, then that normally cures obstructive sleep apnea, and it's very satisfying. We remove the tonsils and adenoids, and then I call them 3 months later, and they say, yeah, well, my OSA is completely gone. The first week was very perturbing because the child was no longer snoring, and I wasn't sure if they were breathing. So it's kind of that sort of improvement that we get. So it's very, very good, very satisfying. Choosing that type of patient to get the best results from your surgery is all about patient selection. So I want 2 out of 3 things to be able to operate and say you're going to benefit from having adenotonsillectomy. And one of those things is in the clinical history, and they normally haven't got to me without that, and they probably haven't got to you without that either. So the mum's coming in or dad's coming in saying, little Johnny, is snoring like a trooper, and then he's having episodes where he's stopping breathing for up to 10 seconds and then sort of gasping, and then sometimes he wakes himself up and sometimes he doesn't. So that is quite a good history, and if that's happening every night, then I'd be thinking, yes, that's a good history for obstructive sleep apnea. If it's just snoring, then I'm less interested. The second thing I want to see are big tonsils. So I'll look in the mouth and I want to see grade 3 or grade 4 palatine tonsils. And if I've got those 2 things, then I would normally offer adenotonsillectomy to the parents. If I've got the clinical history, but I've got small tonsils, grade 1 or grade 2, then I'm less keen to operate. I'm a bit more concerned that if I do operate and put this child, through pain and the risk of bleeding, are they going to have a good benefit? And so those cases I might consider something called a sleep study, and that's a bit of an umbrella term. So you can have overnight pulse oximetry with or without a carbon dioxide tracer. Sometimes that's little cannulae in the nose. And what we'd expect to see on that is with every apneic episode, you get an increase in the pulse rate at the same time as you get a decrease in the oxygen saturation. And seeing how often that's occurring throughout the night's sleep will give you idea of severity of obstructive sleep apnea. And if you're measuring the carbon dioxide level as well, if they're having lots of desaturation and apneic episodes throughout the night, eventually that carbon dioxide level will gradually increase. So at the end of the night's sleep, it would be elevated. So that's a relatively good screening tool, the pulse oximetry with carbon dioxide, and that tends to be our sort of go-to sleep study to begin with. But the most accurate type of sleep study would be a bit more formal in terms of polysomnography, and that's normally where we would admit the patient into hospital for one night, and we're monitoring all the things that we're doing with the first type of sleep study, but we're adding in looking at movement of the chest. So we're monitoring movement of the chest, we're monitoring movement of the abdomen. And what happens with an apneic episode is you get this seesaw movement of the chest and the abdomen, and then they overcome the obstruction, and then that settles down. And we can have audio and video as well, so it's a lot more detailed and it's a lot more accurate. And I would probably think about that in maybe patients who might have had a preoperative sleep study for whatever reason, and then having a post-operative sleep study if their symptoms haven't improved, or if they're syndromic, or if I'm worried about a central apneic cause. So if there's a brain abnormality, for example, that wouldn't represent with obstructive sleep apnea, where the brain might cause you just to stop breathing, but you won't get that seesaw movement of the chest and the abdomen because you're not trying to overcome an obstruction. This sort of just harks back to what we were talking about with the grading system. So grade 4, like in the picture we saw, clinical picture we saw, the tonsils are touching in the midline. Grade 0 is I've removed them. Grade 1 is that they're hidden within the tonsillar pillars, and then 2 and 3 are between, sort of stages in between. So grade 2 is they're just extending beyond the pillars, or just extending to the pillars, and grade 3 is beyond the pillars. So you tend to get a rough idea. It's a bit subjective, but you get a rough idea of what sort of size the tonsils are. Moving on from obstructive sleep apnea, I'll take questions now or later. If we go to recurrent tonsillitis, this is my only slide on recurrent tonsillitis, because I think recurrent tonsillitis is fairly straightforward. It kind of speaks to itself. These are the ICB guidelines, and so it's 7 episodes in 1 year, 5 episodes in 2 consecutive years, or 3 episodes a year in 3 consecutive years. And that's kind of it. I don't really have anything more to say, but happy to sort of accept questions on that, and we can maybe talk about when to treat with antibiotics and things like that. But you probably more expert than I am on when to give that. So yeah, I don't really have anything more on recurrent tonsillitis particularly. Moving on to ears, away from tonsils, acute otitis media. So this is, that acute infection. It's painful. You look in the ear, there's a red, maybe bulging tympanic membrane. They've got a temperature, and I would treat that patient with paracetamol and probably ibuprofen for the first 24 hours. And if it's not settling, then they may need amoxicillin after that. If the tympanic membrane perforates, then I actually think that's quite a good thing, because the pain settles almost immediately because it's not under pressure, and the infection has got an escape route, and you've got an extra source to give further antibiotics. So you can give topical eardrops, antibiotic eardrops, as well as the orals that you've probably given already. Don't give eardrop antibiotics if there's no ear discharge, because it means the tympanic membrane's intact, and those antibiotics are just going to hit the eardrum, but they're not going to get beyond into the middle ear, so there's no point. It's only if the ear is discharging. Complications would be acute mastoiditis, and you tend to get this when the eardrum hasn't perforated, there isn't an escape route, and the infection spreads from the middle ear to surrounding structures. So the mastoid bone is the honeycomb bone behind our ear, and the infection that communicates with the middle ear, so the infection can spread to that, and that's serious because that could potentially lead on to a sigmoid sinus thrombosis, so a thrombosis in the major veins in the brain, and you can sometimes then get an extradural, subdural, or intracerebral abscess. So that's sort of a really important complication of AOM to pick up on. So on the left, you can see a normal tympanic membrane. On the right, it's red and inflamed, and that you'd say that's acute otitis media. If it's bulging, then it's all under pressure, it's quite painful, and then it could become acute mastoiditis. And you can see this little boy here doesn't look particularly happy, and his right pinna is being protruded because of swelling over his mastoid bone. And the little colouring at the bottom, just that little loop here, that's the sigmoid sinus. This is the lateral sinus. And we're just getting a patient admitted to the Children's Hospital this afternoon who may have a lateral sinus thrombosis from acute mastoiditis. So so these are sort of real complications that happen not infrequently. Chronic suppurative otitis media.
Can I interrupt with a couple of questions?
Yeah, please do.
All right, brilliant. So first question is a quick question on tonsillectomy criteria for recurrent tonsillitis. Lots of patients really want their tonsils out because of how miserable their recurrent infections make them feel. How would you explain to them why tonsillectomy isn't the right option for them? i.e., why is the threshold set where it is?
It's set where it is, I think, correctly because of the risk versus benefit. So if you're not getting enough episodes of tonsillitis to meet the criteria, it's because if we took your tonsils out and you have a significant bleed, for example, and the risk of bleeding is probably anywhere between 5 to 10%, then we've probably not done you a good service. We've probably done you a disservice. So it's to do with the risk of the surgery, the tonsillectomy, and primarily bleeding risk. And so we want to operate on those patients that are really going to benefit from the surgery, and the benefits outweigh the risk.
Thanks. And another question as well. If the tympanic membrane perforates and symptoms are better, are antibiotics needed if they've been avoided thus far? It seems that if pus can drain, then maybe antibiotics aren't needed. Or does a perforated tympanic membrane increase the risk of complications?
It's a good question, and I think I'd go on how the patient is, and I'm really interested in what the temperature's doing. So if they're apyrexial, then I kind of think that probably the infection's settling down. If they're still having spiking temperatures despite there being a discharging ear, then I'd probably continue with antibiotics and add in those topical antibiotics.
Thanks.
And keeping the ear meticulously dry as well. So when you've got a tympanic membrane perforation, you don't want to get any water in there.
Thank you. That's all the questions for now.
Lovely. So yeah, so CSOM is a completely different ballgame. This is a much more of a chronic discharging ear that normally happens through a tympanic membrane perforation. The key thing with a persistent discharging ear, though, and it's often you look in the ear canal and all you can see is discharge. You can't see the tympanic membrane, so you're not quite clear, is this through a perforated tympanic membrane, or is there something else going on? And the thing that you'd be worried about is something called cholesteatoma. And this is a condition, it's keratinized squamous epithelium that starts to sort of form in a retraction pocket of the eardrum, and it spreads medially, it spreads inwards, and it starts to erode bone, and it can be extremely damaging. And this is kind of what you're looking at. So you've got the tympanic membrane sort of posterior, and then in the superior aspect, so in the tympanic membrane is inferiorly, and then the superior aspect is this sort of pearly, sort of greyish mess, and that is your cholesteatoma, and that can present with a chronically discharging ear as well, and sometimes conductive hearing loss. So this is really important to pick up, because what they're going to need is something like this. This is a left ear. This is the external auditory canal, the ear canal. And this is the mastoid bone where the soft tissue and skin have been retracted back and it's been drilled out. All the air cells have been drilled out because the cholesteatoma gets trapped inside. And the only way to remove it is with this sort of really significant surgery. So this is a mastoidectomy operation. So yeah, the sooner we diagnose cholesteatoma, the sooner we can try and prevent it spreading too far. This is a condition that you probably see fairly regularly. This is glue ear, otitis media with effusion. This isn't an infection. This is a sterile middle ear effusion, which causes hearing loss. That's essentially all it causes. It doesn't really cause anything else other than hearing loss, and it will resolve. So you might say, well, what's the reason for needing to treat it? Well, we don't want that child to fall behind in their development if they can't hear the teacher or they can't hear their parents talking and they can't then develop their speech. So that's why we intervene. We intervene after we've confirmed that it's a persistent problem, and that's after an audiogram 3 months apart. And what we tend to see is a dull yellow non-bulging tympanic membrane. Is not painful. And if we've got these two audiograms 3 months apart showing a conductive hearing loss with flat tympanometry, that would say that it's glue ear. And the options would be to treat the patient with grommets or with temporary hearing aids. And there's no difference between the two. So I would always offer both options. The problem we've got at the moment is because of a whole host of things, but especially after COVID, our waiting lists have gone through the roof. So a routine waiting patient is probably a minimum of 12, but probably closer to 18 months. And that's coming down, but that's still a long time to wait with no hearing. So we have been offering patients the temporary hearing aids because we can get those fitted within 3 months. Because putting grommets in would take 12 to 18 months. We're still offering grommets, but I think in the meantime, to improve their hearing, then they're better off having something rather than nothing. So they are having the temporary hearing aids. And often that's all they need. Often it tends to resolve by the time they might need grommets, their glue is resolved. This is, again, just looking at an eardrum that's showing glue ear, otitis media with effusion, and then one that's been treated with a grommet. It's a little plastic ventilation tube that's bypassing the non-functioning eustachian tube that goes from the middle ear to the nasopharynx. And as I said before, sometimes the adenoids might be playing a role in causing that, and we might remove the adenoids as well. We tend to remove the adenoids probably after the second set of grommets if they need a second set. Tongue tie was on the list, and I wasn't quite sure what people wanted to know about tongue tie. Ankyloglossia is the actual term, so I thought I'd put this slide on as well, just as a little aide de memoire, but no one calls it that. Everyone calls it a tongue tie. So the NICE guidance states that for a tongue tie needs to be divided if there's difficulty in breastfeeding, and that's their own. And if you look at the meta-analysis, there aren't really any other indications for dividing a tongue tie. So people sort of get very worried about effects on speech articulation. They get very worried about, are they going to be able to clear food debris from their mouth? But if you look at all the evidence out there, there's nothing to suggest that if you don't divide a tongue tie for, it does not affect speech. It does not affect dental clearance. So this is one paper that looked at a whole host of papers. So it was a detailed meta-analysis, and it looked at 378 abstracts. And the data was really quite poor. So after sort of really looking at the sort of decent research that had been done, it only came up with 15. Well, it came up with 15 studies that were observational. 5 were randomized control trials. So that's what we're really looking for in data, randomized control trials. And essentially its conclusion was and well-tolerated procedure that provides objective and subjective benefits in breastfeeding. However, there was a limited number of studies available with quality evidence. There were no significant data to suggest a causative association between ankyloglossia and speech articulation problems. So that, I mean, when patients come to you at sort of age 4 or 5 with a tongue tie, saying that they really want their tongue tie divided, and yes, you'll probably apply for exceptional funding, you may even be approved, but and it's so easy for us to divide it. It's not a real issue, and it becomes very emotive for parents, but in actual fact there's no evidence to say that that child needs their tongue tie divided. There's no real improvement, and certainly no real effects on speech. This is the NICE guidance. I was looking, I'd done a presentation on this probably in 2016, and I thought, oh, the NICE guidance must have been updated by now. It was 2005, and I looked back and it's still the same guidance, nothing's changed. So yeah, so it's still out there and it's still 2005. These patients do not need their tongue tie divided, so they're extending their tongue tip beyond their lower lip and their lower teeth, and they don't, for me that means they've got a very good range of movement, and they're probably, dividing their tongue tie is not going to make any difference. This patient's got a tongue tie, it doesn't extend to the tip, and they may or may not need a tongue tie division, but it depends on what's going on with their breastfeeding. I would just do this in clinic. Under the age of 1, I would normally just do it in clinic. Normally they present within the first couple of months. And I would just have them with their head on my lap. I have a head light, and I just have a little instrument that lifts the tongue up, and then I just snip with some scissors. And sometimes there's a little bit of bleeding, which you just put a little bit of gauze under the tongue for sort of a couple of minutes, and then it settles down. It's not something that's particularly painful. And then the child goes home after 5 minutes. So it's very straightforward. I would divide this if there was difficulty breastfeeding, but if there wasn't difficulty in breastfeeding, then I wouldn't divide that. These patients are probably symptomatic, and you can see that it is restricting their tongue movement. The tongue tie extends right to the tongue tip, and that tongue tip won't be able to extend beyond the lower gum, the lower teeth, or the lower lip. So if again, I think in that older patient, I'd probably do it because it's straightforward, and for the babies that are having difficulty breastfeeding, then I would definitely divide it. Any questions before we move on to another topic? Nothing in the chat. I'll move on to laryngomalacia. Thank you. So laryngomalacia, this is kind of one of the main things that I deal with. And it's the most common cause of stridor in a newborn. It's inspiratory stridor. There's different types of stridor. It tends to be this sort of squeaky inspiratory noise. So it's like a hee hee, that sort of noise. And it doesn't tend to occur at birth, but it typically occurs when they're about 2 weeks old. And it tends to get worse once it presents, before then improving, and it tends to not really be present by the age of 12 to 18 months. And 90% we would treat conservatively. There's a strong association between laryngomalacia and acid reflux. So I'd have a very low threshold for treating acid reflux, even if they're not really demonstrating any other signs of acid reflux. The fact that they've got laryngomalacia means that they will have a degree of acid reflux. Gaviscon infant and ranitidine were my sort of go-to treatments before we were stopped being allowed to give ranitidine. what I started to find is that Gaviscon Infant was causing a lot of constipation. So under 4.5 kilos, 1 sachet mixed with feed up to 6 times a day, and over 4.5 kilos, it's 2 sachets. But I tend not to give that anymore, I must admit, because the number of patients I was getting back saying, oh, it just caused my baby to be constipated. So I just give omeprazole now, and I tend to give about 1 milligram per kilogram once a day as a starting dose, and that normally improves things. The time that I need to intervene surgically is with failure to thrive. So I'm looking at their red book growth chart all the time, and I'm seeing, are they following a centile line? And if they their weight starts to plateau and they start to descend the centile lines, then that's the time that I want to intervene urgently with surgery. And what I do is I look down at their upper airway under a light general anaesthetic, so they're breathing for themselves, and I'm dividing the epiglottic fold. So if I just show you this video, you can see that the supraglottic structures, the structures above the vocal cords, every time that baby's breathing in, they're just getting sucked in, and then they just can't get enough air in, and that's when you're getting the squeaky stridor. So this is the epiglottis. If you imagine the patient lying flat on their back, so the back of their head is here, their face is at the top, and then I'm looking through their mouth with a telescope. These are the arytenoids at the back, so I need to divide the epiglottic fold, the little fold between the epiglottis and the arytenoids. So if we move on to this one, that's happened, and we've debulked some of the arytenoid cartilage as well. And you can see that, this is probably, I don't know, 10 minutes later, that those structures just aren't being sucked in like they were. The child's now got an airway. You can actually see the vocal cord. You can see all the way down their trachea. And this child will be much quieter, if not completely resolved from their stridor. They'll be able to feed for longer and breathe at the same time, and then they'll start gaining weight. It becomes an ever increasing cycle rather than an ever decreasing cycle, and they tend to resolve much more quickly. Other topics I thought people might want to talk about, or ones that I might want to talk about, I suppose rhinitis is something that we get referred, and is not quite clear what's happened before they've got to us. Two little bugbears, I suppose. One is the inferior turbinates are not nasal polyps. So often we'll get referred patients saying they've got, I can see a nasal polyp, but in actual fact, it's just the inferior turbinate that's probably more enlarged. And you often see inferior turbinate hypertrophy in rhinitis. I'll put a couple of slides in a second of what an inferior turbinate looks like versus a nasal polyp. The second little bugbear is that the patients come and say, well, the GP started me on a steroid nasal spray, but it didn't do anything after 10 days, so I stopped it. And I sort of always, if I had hair, I'd pull it out a little bit, because it takes about 2 months for the nasal sprays to really start working effectively. And so it doesn't surprise me that the steroid nasal spray didn't really have any effect after sort of 2 weeks. So when the symptoms are really consistent with rhinitis, I mean, literally all I do is say, here, have this steroid nasal spray, but just take it for longer, and then and judge its effects after 2 months, and then you'll find that it is actually working. Nasal douching and an oral antihistamine complement a steroid nasal spray really nicely, and that's from the European positioned paper on rhinosinusitis. So if they're struggling to have their symptoms maintained on a nasal spray alone, steroid nasal spray alone, then they should really be having these other treatments added in. And I do like Dymista, and you can prescribe Dymista in primary care. And that is a steroid nasal spray, but it's also an antihistamine nasal spray in one. And that's licensed for children over 12 years. So if they're not really improving with your Beckinase or your mometazone, then think about Dymista. So this is an inferior turbinate. So you've got the middle partition, the nasal septum, which is on the left. This is a left nostril, and you can see the inferior turbinate, and that's a normal sort of sausage-shaped structure. And we've got pairs of them either side. You've got 3 pairs: inferior, middle, and superior turbinates, and they're important in heating the air and channeling it in linear airflow down to our lungs. But in inferior turbinate hypertrophy that you see with rhinitis, it often becomes very enlarged. But that's different to a nasal polyp. So a nasal polyp is often much paler or yellow, and they're insensate as well. So if you've got a probe and you prodded the polyp, that child or adult won't feel it. If you prodded it and it was the turbinate, they would feel it and it would be uncomfortable. We don't see nasal polyps in children really at all. The only time we tend to see nasal polyps is in patients with cystic fibrosis. You can see unilateral nasal polyps in adolescent, maybe normally adolescent girls, and that can sometimes be an antrochoanal polyp, and that would need to be removed because it's unilateral and you want to make sure it's nothing sinister. But invariably it never is. But polyps are extremely rare in children, and if you do see a child and you think they've got a nasal polyp, then they may well have an underlying condition like cystic fibrosis. Other topics that we can discuss probably after the presentation, epistaxis. So I'd normally start someone on Naseptin cream, but make sure they haven't got a peanut allergy because it's peanut oil based. And that would be one application twice a day for a couple of weeks. I see quite a few patients coming in and say, oh yeah, I've been on Naseptin cream for the last 9 months. And it's like, oh, that's too much. You know, I would use it for short, sharp treatment bursts, and possibly Vaseline after that to keep the nose moisturized. And cautery, very rarely, sometimes GPs have cauterized a child, but they won't use local anesthetic. And I don't think that's appropriate. I think children should have local topical anesthesia. So a bit of local anesthetic dipped in cotton wool or sprayed into their nose, and then have silver nitrate cautery because it is quite painful, it burns, and you want to minimize any distress to that child. Other things that I'm predicting might be of interest might be how to deal with persistent cervical lymphadenopathy and asymmetric tonsils, but we can talk about that. But that's probably all I wanted to say. So I'll end the presentation, and I'm really happy to accept any sort of questions.
We've got one question in the chat. Do you want to see all children with laryngomalacia, or are you happy for us to reassure the parents of children with mild symptoms?
I think if the history is typical and there's no failure to thrive, then I don't think they all need to be referred. No, I think if there's different causes for stridor, so I think you just need to be very happy that you've got the right diagnosis. But yeah, you know, that sort of typical squeaky stridor came on 2 weeks after birth, getting a bit worse. They're a bit, a bit sicky, a bit vomity. You start them on omeprazole, see them a couple of weeks later, they're better, but not perfect, but they're thriving. That's probably all fitting nicely with laryngomalacia.
And I don't know if you can see the chat now that you've closed your presentation.
Yeah.
We've got a couple of requests. So a request to tell us more about asymmetric tonsils, and another one for persistent cervical lymphadenopathy.
Yeah, I mean, I thought these are quite sort of difficult ones that I find to manage actually. Let's talk about asymmetric tonsils to begin with. So in the past, that was one of the indications for tonsillectomy. We'd send them off for histology, and we'd always find that they'd come back normal, but we always did it. Anything, there was a mantra in ENT, anything asymmetric in ENT, think malignancy until proven otherwise. In children, you're thinking about lymphoma. That's the only real malignancy that you're worried about with tonsillar asymmetry. In adults, it's different. I looked back at the last probably 15 years that we'd taken tonsils out for asymmetry and sent them off to the lab, and in that 15 years we did about 300. Only 6 came back as showing malignancy lymphoma, and of those 6, the diagnosis was kind of obvious before we'd even done it. So I don't really take tonsils out for asymmetry alone. Normally what you find is one tonsil's more prominent and the other one's a bit more hidden, and when you do take them out, they're actually the same size. So I think if the overlying mucosa looks normal, there's no sort of ulceration, it doesn't look grossly abnormal, there's no significant cervical lymphadenopathy, what I'm doing at the moment is I'm just keeping a close eye on them, seeing them back in my clinic in 3 months, and if that's all okay, then I'll probably discharge them at that point. You can do some blood tests, and if the LDH was extremely raised, then that would be very concerning for lymphoma. But in those 6 cases that had lymphoma, I think only, I mean, they had there was a few that had raised LDHs. Only one was massively raised. It's a bit of a weak predictor, I think, of malignancy or lymphoma. So I don't think you can rely on blood tests alone. So it's a bit of a long-winded way of saying it's a bit of a sort of a grey area, but the take-home message is that almost invariably, if that child is otherwise well, no weight loss, no nights, no significant cervical lymphadenopathy, and the overlying mucosa looks normal, then to me for histology. Cervical lymphadenopathy. We've tried to put some guidance together on this. If a child's got a lymph node over 2 centimeters, that's concerning. They probably need an excision biopsy. If it's 2 centimeters, I think they should be referred. You're getting a lot of rejections if you're trying to send patients for an ultrasound scan before you've referred them to ENT. So look, I think, if they've had an infection and they've got cervical lymphadenopathy, if it's over 2 centimeters, I would send them to us. If it's under 2 centimeters, I would probably keep an eye on them, probably do a battery of blood tests. I'd normally do a full blood count, U&E, CRP, Epstein-Barr virus, cytomegalovirus. I send for toxoplasma as well, and I send for an LDH. But I think, it's one of those ones where if you've got concerns, refer them if it's persistent. But that's, I don't take many lymph nodes out. I'm normally treating them conservatively. Lot in the chat. I'm missing a lot of the chat.
Yeah, that's okay.
Sorry, Ruth. I was just going to say it's great that Glenda, I think, is here. I did see, Glenda's on the call, and we've worked together to sort of update the urgent suspected cancer kind of referral form, and alongside that, Julian, are going to launch the sort of management of lymphadenopathy in primary care guideline that I know you've inputted into with Flo and Rosie, I think. So that is definitely coming, and I think it features on our slides at the end, Ruth, as a heads up. But I don't know, Glenda, I know you ophthalmology, because it encompasses all sorts of different presenting symptoms, including an absent red reflex, and ophthalmology perhaps hadn't engaged quite as quickly as some others. Do you have a date when you think we might be able to go live, just for the benefit of those who joined?
Yes, so we were going to go live, weren't we, Frances, without a response from ophthalmology, because they had given us a response, and then they responded just as the form was all kind of sorted and ready to go live. So I did chase them again last week. So I think I may be in a position of just sending them an email again saying we are just going to go live with this, because it's just holding us up, and we'll just have to release another version of the form if you want the absent red reflex pathway to change from turn up to ED.
Okay. Great, thank you. And on the new page for urgent suspected cancer for children and young people will be the management of lymphadenopathy guideline as well. But as a general paediatrician, that is by far the commonest reason for referral on the 2-week wait pathway, and the vast majority of it is reactive and absolutely nothing to be concerned about. But we really recognise that it's often of significant concern to the family, so it can be quite difficult, but the vast majority we reassure, we don't investigate. So yeah, we've got the sort of red flags on there, haven't we, Julian? But it's really common for children to have persistent mild lymphadenopathy.
I think when the guidance comes out, hopefully it will be quite easy to follow. So hopefully it'll be helpful. I'm just looking at the chat. So I've got Leslie Barker asking about not giving topical treatments in tympanic membrane perforation. You're absolutely right. There's a theoretical risk that some eardrop antibiotics could cause ototoxicity, but ciprofloxacin doesn't. So you're very safe to use ciprofloxacin eardrops with a tympanic membrane perforation. So that's probably the one I would choose. We use all types of eardrop antibiotics for up to 10 or 14-day course, and we're not worried about ototoxicity. But you're right to raise it, and I think if you're worried about that, then ciprofloxacin is the eardrop to use. It comes with there's one that comes as ciprofloxacin and dexamethasone Silodex, so you could use that. And in the context of a well child with slightly asymmetric tonsils, happy for us to monitor in GP. Yeah, happy for you to monitor in GP. As glue ear gets better on its own, should we be using hearing aids anyway? Yeah, I mean, as I said, I offer hearing aids or grommets. I think people in the past didn't. I think there was a lot of. I think we probably forget, but there's been a lot of what's the word? Sort of discrimination, I suppose, to seeing a patient with hearing aids. It was a lot of people sort of judged people incorrectly, and so a lot of people didn't want anything on show. They wanted grommets which were all nicely hidden. But I think people are moving away from that now, and there are complications with grommets. You can end up with a persistent tympanic membrane perforation. Yeah, so hearing aids or grommets equal. So when my son had grommets, the audiologist told us hearing aids weren't that good in glue ear due to fluctuating. No, so no, I disagree. I mean, normally the glue ear is persistent; it's there all the time, so there isn't a fluctuate. If it's fluctuating, then it probably doesn't need treatment. Looking forward to the guidelines on lymphadenopathy. Yeah, we had a look at those a while ago, so hopefully they're almost completed and on their way to you. Is there evidence that adding in topical to oral is any benefit? Before we step outside local guidance, it would be good to have evidence, especially. Well, I mean, I don't know why it would be stepping out of local guidelines. Probably the guidelines are incorrect then. Clearly, if you've got a middle ear infection and you've got a way of getting antibiotics straight to the heart of that infection, that's the treatment you want to be giving. So all antibiotics are less effective. If you've got a hole in the eardrum and it's a middle ear infection, then getting antibiotics straight there is going to treat it. So yeah, I suspect the guidelines are wrong. Yeah, any other questions? I think we might have finished 10 minutes early then. Ruth, did you want to ask anything?
Yeah, I had a good question, which is probably a silly one, but had a patient who, so a child who had recurrent otitis media, kept having these perforations and had grommets put in, and that slightly confused me. So I would assume, but I just wanted to check that the reason behind that would be that even though they kept having recurrent perforations, there was still a lot of fluid behind the ear and the hearing was affected, and therefore grommets are still a benefit, even if these are children that are really prone to having perforations. But is that right? It seems a slightly odd choice.
So we've got two conditions, haven't we? We've got otitis media with effusion, which is glue ear, which is hearing aids or grommets. And then this child was having recurrent acute otitis media. And so there's different treatment options for that patient. One is regular oral antibiotics every time they have the problem. The other one is prophylactic antibiotics like trimethoprim. Another one is to check their functional antibodies to see if they've mounted a suboptimal response to their vaccinations and they might need a booster. And then another one is putting grommets in, because there's probably an underlying eustachian tube dysfunction here that's causing them to have these recurrent infections. You know, whether that is, you know, the eustachian tube not working properly, or it's wider, shorter, and more horizontal, so bacteria in the nasopharynx are ascending up to the middle ear. But putting grommets in can be a treatment option for recurrent acute otitis media, and it just bypasses that issue with the eustachian tube. Sometimes the grommets can actually make things worse, and then the grommet can be a focus to the infection. So there's pros and cons, but we do sometimes treat recurrent acute otitis media with grommet insertion.
Thanks. Oh, I think we've got one more question before we move on.
So perforation can be extensive result. Yeah, exactly. So with those patients with a perforated tympanic membrane that doesn't seal close within, say, a week of keeping the ear dry, they're then getting into that group of chronic suppurative otitis media that I was talking about earlier. But a grommet that is controlled, a little, radial slit, grommet sits in there for about 9 months to a year. It eventually gets pushed out, and the eardrum closes. The chance of a chronic tympanic membrane perforation after a grommet is about 2%. So it's quite unlikely.
Brilliant. Thanks so much, Julian. So before we let everyone go, we're just going to steal a few minutes at the end, if that's all right, just to signpost to other educational opportunities and changes on Remedy. But thanks so much, Julian.
Thanks. I'll leave then. Thank you very much, guys.
Thanks.
Bye-bye.
Thanks, Julian.
Right, so I'm just sharing my screen. Brilliant. So I'm hoping that you can see that okay. Do shout out somebody if you can't. So this is just signposting to our next forum, which is on the 14th of May. So it's a little bit earlier than they normally are in the month. But we've got Charlotte Lowe, who's going to come and speak to us on developmental delay. So that's date for your diary. And I'm hoping that Millie is very kindly putting a link in the chat for this now. But if not, if you go on the BNSSG Training Hub homepage, it should be, the link is there under the What's On tab. So you can find that there. So I'm sure you're all well aware of it by now, but on the BNSSG Training Hub page, under resources, there is a child and young person education page, which has now been made as a central point for all of these educational activities that are going on. So we've got the BNSSG Peds Pod. So episode 10 has literally just been released this morning, which is on health inequalities, so worth checking out, but you've got a link to all of the ones that are out so far there. And we've got the forum here as well. So, I mean, this is a slightly out of date screenshot, but you'll be able to sign up to the next session, so developmental delay in May. And almost all of the sessions have been recorded. So the only reason we wouldn't is if we can't for confidentiality reasons. So if there's any that you've missed and you want to play back, then have a look there. And equally, if there's any more face-to-face events, anything else that's developed, they will come up on this page. And you can join the mailing list with the link at the bottom just to be updated on what's going on. I'll hand over to you, Frances, for this slide and the next one.
Yeah, apologies to people who've seen this before. So just a summary of the currently available advice and guidance services. So separate services for general peds in Bristol and North Somerset, and then a smattering of others, but no general surgery or trauma and orthopaedics. So unfortunately, we can't answer, generally we wouldn't feel confident to answer those questions. But there is an ENT email address for advice and guidance rather than via ERS, and an email address for CAMS as well. And just a little plea to put your questions in the text box rather than a separate letter, and I appreciate that's often arranged by the admin teams, but it's much more efficient for us to have a question in the text box. Just saves the number of forms that we have to print to our medical record system, and if a child's already known to a consultant, please contact their secretary directly. And I think we've touched on this already, haven't we? So I know Glenda's on the case with hopefully getting this out as soon as possible. So it's all sort of ready to go, but just awaiting the final kind of part from the ophthalmology perspective. And as I mentioned, that when this is released, the new page will have a link to management of lymphadenopathy in primary care as well. And then hot off the press, it's not on the slides. We've just had approval of a guideline about labial adhesion, so I'll make sure that that gets on to Remedy as well. And then the next one was just a reminder that we're really pleased to now have a BNSSG-wide children's continence service, so that's nurse-led, and you can refer directly via the single point of entry form. So that's obviously the criteria outlined in the page on Remedy, but rather than referring to general paediatrics, these children go straight to a nurse-led continence service. So yeah, really pleased that that's in place. I think
and then the final
oh, you've got one more.
Yeah, just the final thing to highlight here is that there is a session, so it is paid for, and it's primarily aimed at people working in urgent care or emergency care. So may not be applicable to everybody who's listening, but there is all in a day's work, which has been produced, and that's in September. So date for the diary for anybody who's interested for that as well. Great, I will stop sharing. If anybody didn't catch that in time, feel free just to drop me an email. Brilliant. Thanks so much, everybody, for coming. I can see that we've got the feedback form on the chat, so please do fill that in before you go. There's the sign up to the next session, so 14th of May, the developmental delay, and a link there as well. Thanks very much, Millie, to the Child and Young Person page.
Thanks everyone for joining, and look forward to seeing you soon.